Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. Today we have very special guest, Dr. Danielsen, joining in from Denmark, and we're talking about a very important topic around hypodermoclysis, or also known as subcutaneous hydration or infusion. So, Dr. Danielsen, welcome to the studio. Happy to have you, but I'm going to allow you an opportunity to talk a little bit about yourself, maybe your experiences, and anything else you want to share about yourself that brings you on to today's episode.
Thank you, Derek. I'm happy to be here. I'm a medical doctor, and in my last year, becoming a geriatrician, so I'm almost a consultant in geriatric medicine. I've done a PhD on subcutaneous hydration and is researching on hydration in older patients. So this is my key area, my area of interest. And I'm very happy to be here. I feel that subcutaneous hydration is an underused technique, and I think the main barrier actually is lack of knowledge. So being able to talk about and discuss subcutaneous hydration on your excellent platform is a great opportunity for subcutaneous hydration, I think. So thank you for having me.
Yeah, wonderful. And I think like you said, it's underutilized and it's not discussed often. So I thought it'd be a great opportunity with some of the recent work that you've published to bring you on and talk about that. So let's go ahead and start out with the big question. Why are we still talking about IV hydration first, when the evidence may suggest that subcutaneous hydration may actually be a better option for many patients?
I think it's important to understand that intravenous hydration is an effective method of hydrating our patients. The fluid gets pretty much where we want it fast. We can give large volumes to our patients. So the patients with severe dehydration or with shock of different types, they need a lot of fluid fast, and IV hydration is the correct choice when the patient needs this effective treatment. However, especially in geriatric medicine, we have a lot of patients where the oral fluid intake is insufficient. So they don't need large amounts of fluid. They just need what they should be drinking, but isn't. So here we have a subcutaneous hydration as a way of giving them a liter or two a day with a very easy method of treating them. Yeah. So I disagree that subcutaneous hydration is the better option for all patients, but for some patients, it is certainly a better option.
Thanks for that clarification. So for infusion nurses who maybe never heard of or used hypodermoclysis, can you walk us through exactly what subcutaneous hydration is and why it's been underutilized for so many years?
So subcutaneous hydration is a technique where we place an access or a needle inside the subcutaneous tissue on patients, and then we infuse the fluid into the subcutaneous space where it is absorbed into the bloodstream. So there's like an extra step compared to intravenous hydration. And IV hydration it works, intuitively works. It's easy to understand. And a lot of the patients we have need intravenous therapy anyway, so why make an extra access? So I think there is an absolute need for IV treatment. There is an absolute need for IV hydration, but there isn't an absolute need for subcutaneous hydration. So it's an add-on more than a necessity. I think that's why we don't use it. I also think that placing IV accesses gives a certain satisfaction when you hit the vein and you place it and it first try and everything. That's nice. Subcutaneous hydration, the subcutaneous access is very easy to place. You don't get that satisfaction of hitting the vessel, and so I think a lot of both doctors and nurses prefer the satisfaction of knowing that they're good at what they do when they place the IV access. So I think that's the main point. I also think that this focus on the geriatric patient and their hydration need is increasing. Understanding that their they don't drink sufficiently, and we need to help them with this to avoid a lot of complications in these patients. So I think the hydration focus has increased, and therefore how we deliver this hydration has also increased, increasing the need for subcutaneous hydration, or the relevance for subcutaneous hydration.
Yeah. So a recent publication of yours that I read that brought interest and sparked my interest on reaching out to you for this episode. You really focus heavily on patients with delirium and dementia. I know you talked about there are specific types of patients that this is a better fit for, and I'm assuming this may be those types of patients, but what makes this population uniquely suited for subcutaneous hydration?
Well, there's two reasons why this type of patients is relevant. The first is that these type of patients often have an insufficient fluid intake because of their cognitive impairment in some form. So the need for hydration is larger in this group than it is in the non-cognitive impaired group. And the other reason is that, as I'm sure all clinicians working with patients with dementia, with cognitive impairment and delirium know, they have a tendency to remove any IV access they have, and that's quite a big problem. But the subcutaneous access is much easier and faster to place in this population. And because we can place it out of sight. So when you place an IV catheter, you place it on the arm or the hand, and that's visible every time you eat or you look at your hand and something is there and you don't know what it is. While the subcutaneous access we can place on the abdomen or the thigh and cover it with cloth, and then it's gone. And the delirious patient doesn't know it's there because they can't see it, so it's not a problem. And furthermore, when they remove their IV catheters, sometimes there's blood everywhere and it's a whole mess, and you need to clean it up and you need to place a new one. But when they don't remove the subcutaneous access as much. And when they remove it, there's no blood, just the infusion fluid slowly dripping out of the catheter. So it's not a big deal. Just remove the. Maybe you need to change the bed linen if it's really wet and you spend a lot of time before noticing it. But it's much more invasive for the cognitive impaired and the confused patient, the work we need to clean up when they accidentally remove their catheter.
So, I noticed that one of the more striking findings was the reduction in agitation and catheter dislodgements. We kind of just hit on that. But do you think that we're actually preventing delirium, or are we simply removing the triggers that contributes to it? So like you mentioned, out of sight. I mean, do you think that's the true causation behind this?
Well, that's an excellent question, and I would love to answer whether or not we are actually reducing the incidence of delirium. And there's no question in my mind that if we were reducing delirium, if we had solid proof that we are reducing delirium, it would be much more on a much more bigger scope subcutaneous hydration, but we aren't there yet. The studies we have are done in the cognitive impaired, and we see a large 60% reduction in agitation in these patients, so not delirium. Based on both the research and my clinical work, I think we are reducing delirium, or at least the intensity of delirium in these patients. And I would also argue that even a small reduction in delirium in these patients, or a reduction in the complexity or the severity of delirium is relevant, because it's a very, very serious condition. So let's say we have 10% reduction in delirium with changing from one method of parenteral hydration to another. That's worth going for. So the bar for how much effect it will have is actually very low. And what I will say is that I feel confident in saying that we aren't increasing the risk of delirium. How much we're reducing it, I don't know. But we are certainly not making anything worse. So the argument for not using is difficult to see, actually.
Yeah. So infusion nurses are spending a tremendous amount of time replacing IVs that patients have pulled out or dislodged for various reasons. We find that across the spectrum with all patient types. But specifically, if we could reduce dislodgement by 80%, what would that mean for patient safety, nursing workload, and healthcare costs in general, from your perspective?
I think that it's a patient group requiring a lot of, if we're looking at these cognitive impaired where the 80% reduction is from, we would see a lot of, trying to phrase it properly, the reduction is relevant because it's the work needing to place it and the disturbance of the patient needing to replace it is very relevant. I think this what it will do economically is difficult to say, because I don't think we're going to reduce the number of nurses needed at any given shift. So I'm not sure there's much economical gain there, but I think that the nurse's time will be spent better caring for the patients instead of trying to place the IV catheters.
And that's where I think that I would position that as well as redistribution of focus within your shift or reallocation of that time spent on other pertinent tasks. So.
Yeah, exactly. If we reduce the severity of delirium or even reduce delirium, there might be a financial gain, but we don't have data to support that yet. So
yeah. It's good. It's an interesting perspective to think through and try to determine what those outcomes are and correlate everything. But thank you for that. So can you paint a picture of what an ideal patient for subcutaneous hydration, who should make us stop and think, maybe this doesn't need to be an IV? So for the nurses that are considering maybe this as an option or asking or inquiring about including that within their plan of care, what does that patient look like?
well, the common patient we use it in is the geriatric patient with some sort of cognitive impairment. So that could be either a known dementia or an unknown dementia or just delirium. They're usually acutely admitted. Maybe they have a urinary tract infection and they are confused. They don't drink sufficiently, and we don't really have the resources to make sure they drink enough. We don't know if it's because they have swallowing difficulties or what, but they aren't drinking sufficiently. And we know with the urinary tract infection, hydration is relevant. They might have an IV placed because they need IV antibiotics, but what we do is we give the antibiotic as a bolus infusion, so over 5 to 10 minutes, and then we close it off and hide it beneath gauze or whatever, and then we place the subcutaneous access on the stomach, and then we give them slowly fluid infusion there. That's the ideal patient. And the other patient where we use it very commonly is if a patient receives antibiotics via CADD pump, so a continuous infusion that uses up the IV all of the time. Instead of placing a secondary IV, we just use subcutaneous hydration and parenteral hydrate them that way.
Yeah, so just so I'm understanding, so you're recommending that if someone is maybe prescribed IV medication intermittent, it's okay to you can still have an IV and you utilize subcutaneous as well. That's what you're saying.
That's what I'm saying.
Okay.
It seems that when looking at why patients are removing their catheters, it's more common in continuous fluid infusion than it is in bolus treatment of antibiotics. So with a short treatment of antibiotics where the nurse is able to stay by the patient's side these 5 to 10 minutes and then wrap it in gauze and then leave, that there isn't much to remove there, but the continuous fluid infusion going on over many hours, 6, 8 hours maybe, the risk that something goes wrong in that time span is very high. So by only giving these short bolus infusions and then leaving the long infusions to the subcutaneous access, we reduce the risk of catheter dislodgement or removal.
Wonderful. Yeah. I don't think that many clinicians are maybe even thinking along those lines. So that's a great perspective and a great catch for many of our patients out there. So thank you. So on the flip side, when is sub-Q hydration absolutely not the right answer? So maybe you could talk through some of the limitations and contraindications that clinicians need to recognize.
Yeah. So as we discussed in the beginning, when the patients is severely volume depleted or hemodynamic unstable, they need fluid and they need fast, and subcutaneous hydration does take some time to reach the bloodstream. So when there is a large need of fluid, fast, subcutaneous hydration is certainly not the right choice. When the patient has severe subcutaneous edema, then subcutaneous hydration isn't the relevant choice because we just add to that edema. So that's also a contraindication. And then if with severe electrolyte disturbances, it isn't examined whether or not subcutaneous hydration is safe. So I wouldn't recommend it there. That being said, in my own work, sometimes when we cannot place an IV access on the patient and we're discussing what are we going to do, are we going to place a midline on this patient to correct hypernatremia, for instance? Then we'll do it subcutaneously. This is the least of two evils. So sometimes in real life you have to find the correct choice, even though there's no evidence backing it up. Yeah. So I would say that's the contraindications. And finally, in some patients with very low levels of albumin, we aren't sure whether or not the fluid from the subcutaneous space is absorbed into the bloodstream. but we did a study a couple of years ago where we took patients that were admitted to our geriatric ward, so acutely hospitalized, most of them for an infection, a few of them after a hip fracture. And then we gave them a subcutaneous infusion of fluid where we mixed in a radioactive isotope. And then we could see how fast, after giving the infusion, the fluid was absorbed from the abdomen and when it appeared in the bloodstream. And we showed that in this relevant patient group that about an hour after the end of the infusion, 90 to 90% of the fluid we had given had been absorbed into the bloodstream. So if the patient can wait this hour before the treatment is active, then subcutaneous hydration is probably a reasonable bet.
Wonderful. So many infusion nurses are what we could say experts in vascular access, but they maybe have not been trained on sub-Q access. How technically difficult is this placement? Maybe what sites do you prefer, and what practical tips do you have for these nurses?
So I think give me 5, maybe 2 minutes with an experienced nurse, and they will be comfortable in placing subcutaneous access.
Okay.
It's very, very easy. So my recommendation is placing it on the abdomen, lateral to the umbilicus, or on the thighs. So it depends a bit on how easy it is to get to, but the abdomen is usually quite easy to get to, and the hose from the infusion will slowly slip out under the shirt, so the patient won't really notice. So if I should go through the steps, so the first would be make sure there's indication for the therapy. Ensure that the skin on the abdomen is not with edema or rash or anything else where we don't want to put a needle into. And again, if you have an experienced nurse, I'm sure that makes sense not to poke in something that looks not right. And then, of course, make sure you use correct antiseptic technique as if you would place an IV access. And that's the boring part. And the part that the nurses don't know is you take a lump of skin and then you poke a needle in, and that's it. And then you secure it. So unless the patient is extremely thin without any subcutaneous fat on the stomach, where we might theoretically be afraid of poking through the abdominal wall or something like that, it's very easy. For most of us, most of the patients who has some tissue or fat on the stomach, take a lump, put the needle in, you're done.
Deal. So not as challenging. So I think sometimes we can psych ourselves up or think something's more than what it is per se. So thanks for clarifying that.
I think every time I've been out and teaching nurses in this, and they say, is it that easy? And yes, it is surprisingly that easy. I know I sound like one of those TV salespersons, but it is really that easy.
Yeah, I was part of faculty on a course where we taught hypodermoclysis, and that was a common reaction. They did not assume that it would be that easy, that quick, right?
No.
So yeah, that's a common reaction I received as well. So the INS community is deeply vested in vessel preservation and choosing the least invasive therapy necessary to get the treatment done. Do you see subcutaneous hydration as another tool in the vessel health and preservation movement?
Yes, I do. And that's when we're discussing whether or not a patient should receive subcutaneous hydration and how we should hydrate them with the nurse I'm working with, we always discuss if we use subcutaneous hydration instead of IV hydration, then we maybe save that vessel when they inevitably remove the catheter or when it just doesn't work anymore. So vessel preservation and using for later when the need will be is very relevant. I think sometimes we are placing, I don't know, PICC lines, what are they called? The long ones under the skin, right? That is a more complicated procedure. And if we can avoid that, avoid spending workload on that, I definitely think vessel preservation is a relevant choice for subcutaneous hydration. I don't remember ever running out of places to put the subcutaneous needle for hydration. Yeah.
Wonderful. So now we're going to talk a little bit about the future. So we're looking ahead, say 5 years. What do you hope changes? Do you maybe envision hypodermoclysis becoming a routine option in emergency departments, acute care hospitals, long-term care, and even in home infusion? Or are there barriers that we're still working through within those areas?
I think the main barrier for subcutaneous hydration is the lack of knowledge. So usually we need a doctor that's comfortable in prescribing subcutaneous hydration, and you need a nurse who's comfortable placing it. So I still sometimes, when I'm not where I'm usually working, the nurses say, "Oh, we're not going to place that," and I need to place that, and they say we're not going to be using it. So there's a barrier there. And in 5 years' time, I hope that meeting colleagues, especially younger nurses or younger doctors who are unfamiliar with subcutaneous access and subcutaneous hydration, will be a thing of the past. That will be a nice prospect looking into, because the main barrier is lack of knowledge. In the emergency department, sure, it's relevant sometimes, but mostly in the elderly patients where we're saying you don't need acute care, you can return to the long-term care home or home, and we will give you some parenteral hydration to make sure that you are improving. But the patients who need acute care probably need an IV access, they probably need a faster treatment. But certainly, once they're done in the emergency department and up at the ward and a few days has passed and they aren't drinking sufficiently, subcutaneous hydration is an excellent choice and should be available everywhere where older patients are being treated. And long-term care homes and even in home care, I'm certain that that is relevant and should be available to all patients there, and should be something that everybody who works in those places should be aware of. Yeah.
Yeah, definitely another tool within the patient's plan of care that we should be implementing.
One of my key concerns with subcutaneous hydration in the cognitive impaired patient, so a patient with dementia who stopped drinking sufficiently as a consequence of their dementia, probably shouldn't be treated with artificial hydration. And this prolonging death, I think, is a wrong way of seeing it. And while IV hydration is more difficult, so there's a barrier in doing it, subcutaneous hydration is very easy to place. And I think there's a risk that we are continuing to treat patients who are at the end of their dementia and at the end of life with hydration where there is no proper indication. And I think that's a concern that needs to be discussed, because it is so easy to place and so easy to treat the patients with hydration this way.
So running out of time, but I still have a few things I want to get out of you. So, okay, so for question 1, what's the biggest myth about subcutaneous hydration?
That it doesn't work. The fluid will stay in the subcutaneous space and never enter the bloodstream.
So does the patient feel more comfortable with subcutaneous hydration versus IV?
They don't care. Most of the patients treated don't care.
What's the maximum volume you feel comfortable administering?
2 liters a day.
Are there medications that can be co-administered subcutaneously that clinicians often overlook?
I know this is a rapid fire, but this is a more complex question, because there certainly is.
Yeah. Well, we can slow down. Yeah. If it deserves some extra attention,
go
ahead.
At some antibiotics you can treat the patient with subcutaneously, and I think that's very interesting and something we're working on implementing where I work, because with the difficult IV placements, there's certainly a space for subcutaneous antibiotics, but you need to make sure that you're using antibiotics that is safe to use in the subcutaneous space. And I think that is something to look into in the future. And subcutaneous medication has been used in palliative care treatment for a long time. And I think all of that medication we are used to giving subcutaneous in the dying patient. But some of that can easily be moved to the not dying patient, such as loop diuretics is a common example that I'm trying to move a bit more. We shouldn't be placing IV accesses to treat them with loop diuretics, because subcutaneous, that works as well.
So one more question. If you could change one hospital policy tomorrow regarding hydration, what would it be?
So I think the one hospital policy would be that every geriatric patient admitted to the hospital needs to have an hydration plan from day one and needs to be updated. So it's not something we do as an afterthought, but an active thought with every patient that enters our hospital.
I concur with that. All right. Well, that's all the questions I have for you, Dr. Danielsen. I really appreciate you coming into the studio and having this important discussion with us. Before we wrap up, do you have any final thoughts?
No, thank you for having me. I love discussing subcutaneous hydration, and I could easily spend an hour more talking about this interesting subject. But I understand that we need to end here, and I think most of the important points of subcutaneous hydration has come across, so I'm very happy.
And I will put your publication in the reference, so anyone interested in reading that or getting contact information, you'll have that access directly if you go to the reference section of today's episode. So, all right, with it and that. So, as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.